All right, good morning, everyone. I'm super excited to present the speaker for our annual Women's Council Grand Rounds today, which is Dr. Justin Bullock. Dr. Justin Bullock is a UW Research Nephrology Fellow, and he is also a PhD candidate at the University of Maastricht in the Netherlands, studying health professions education. I have a paragraph, but I'm just going to kind of go off memory because Justin and I are actually really good friends. And as part of the reason why he's here today is because his work is just incredible. And I felt that as someone from a different department, he has so much to teach us. And I think that as surgeons, there's going to be so much that we can appreciate and learn from Justin's work, especially as it relates to improving the learning environment and changing culture, which are things that we've been talking about a lot recently. Justin is really passionate about creating safe environments in medicine where everyone in the hospital can be their authentic selves at work and work together in the spirit of healing. His primary research focuses on how educators can minimize identity threats in the learning environment. In addition to all of his scholarship, Justin is very outspoken about his experience as a gay and Black bipolar physician. His work and his story have been featured in numerous journals, such as the New England Journal of Medicine, Vox, Forbes, and others. Drawing on his dual identities as a patient and a provider with serious illness, Justin deeply believes that medicine is a lifelong journey of healing for us as much as it is for the providers and the patients. I'm so excited to have Justin here today, and please welcome him warmly.
Thank you very much. It's a special honor and privilege to get to be introduced by Dr. Desari, someone who is a very, very dear friend and someone who I respect very immensely as a medical educator, and I've gotten to work with in a lot of different contexts on the transplant nephrology side. So I actually changed the title of my talk kind of at the last minute. I'm now calling this Reimagining Safety in the Learning Environment. And the punchline that I'll give to you all for the entire talk is hopefully by the end, I will have convinced you that if you care about equity for trainees or for patient outcomes, that we must attend to the learning environment because it fundamentally deeply influences the care that we provide. So again, and very appreciative to the Surgery Women's Council for inviting me to come and speak. I do not take it lightly that I'm a man who's now beginning a platform to talk. I think the things that I'm talking about very much relate to gender equity and equity for people of all identities. So let's jump in. No disclosures. So I have three objectives. The first is to talk about identity threats. I'll define what that is and how they impact learners in the learning environment. Second, we're going to do a compare and contrast of first responding to identity threats and talking about how that's different from a construct that I would like to introduce to you all called identity safety. And then we'll talk about identity safety and how we can leverage it to improve equity, recruitment, and retention, in particular for folks with minoritized identities in the learning environment. So, and can you hear me? Should I? One second, I'm gonna try this. So I identify as a critical theory scholar, I guess a young scholar in this space. And what critical theorists believe is that power is the fundamental substrate that underlies many, if not all, social interactions. And if you want to fix disparities in our society, we must understand and attend to power. There are many different forms of critical theory. You've probably heard about critical race theory. That's been in the news recently. There's really kind of critical theories associated with each various identity group: feminist theory, anti-colonial theory, discrit, which thinks about folks who have disabilities. And the sort of father of critical theories is this man named Paulo Freire. And he's a Brazilian philosopher, and he basically talks about in society, there are people with power and there are people with less power. And if we look at societies across the world, we'll see that there's this constant battle where those with power are trying to hold on to it and those without power are trying to get it. And he would argue that instead of fighting in the sort of same battle that we've always been thinking of power as a very limited resource, we need to reframe the way we think about power. to truly change society. And I share this with you because this is the philosophy that underlies my thinking and our team's thinking for all of this research. And I would ask you to hold that as we go through the talk. So for instance, this is an image that I'm sure many of you have seen in some form at some point in your lives, comparing equality, equity, and justice, where equality is equally distributing a resource regardless of one's starting position. Equity is unequal distribution of resources in a way that achieves an equivalent outcome. And justice is sort of rethinking the system and sort of not creating barriers that result in people having to distribute resources. I've seen this image many times, and it wasn't until I got into my studies that I began to see a major flaw with this image. Implicit in this is that the tall person here is somehow a superior individual to the short person, because the tall person would never be able to view the baseball. The tall person would always be able to view the baseball game without any support, and the shorter person would never be able to. And instead, I love this image, which is from Nicholas Barcelo at UCLA, who basically says, in reality, what we have are three people who are variably disenfranchised by society. And what we see as this perceived height difference is actually just difference in opportunity or power. And I think this framing, this to me really highlights, what we can gain from thinking about power. We see these dynamics very much at play in medicine. I think there's a very clear leaky pipeline in medicine that individuals, women and underrepresented minorities in particular, enter medicine at higher numbers, and at every single step of the medical pipeline, we see that we're losing people, and to the end where we have only 1/3 the representation for women and underrepresented minorities that we did starting or enrolling in medical school. And I think it's important to think about what are the power dynamics, what are the factors that are at play that are causing people to leave, to have this leaky pipeline. Something that I say in all of my talks is the solution to fixing the leaky pipeline is not to just increase the flow coming in, it's to patch up the pipe so we don't lose people along the way. Dr. Ariane Tehrani is a researcher at UCSF, and she's done some work thinking about basically assessment disparities in learners. And this is a fishbone diagram. It's a complicated diagram, but the important thing from here is that a fishbone diagram is a visual representation of the multifactorial contributors to an undesirable outcome. And what you see if you look on the right here is that, when we think about particularly minoritized learners, there's a lot of evidence that shows that people from minority groups have lower honors in medical school, they get fewer awards, they are less likely to advance, there are pay disparities, et cetera, all these things. And the important thing from the left side of the diagram is that there are some factors that disproportionately impact individuals from minoritized backgrounds. And those are really the key things that lead to group differences in performance and in assessed performance. So I'm going to start to unpack some of these factors, and then we'll talk about what we can do about it. I'm going to start with something called stereotype threat. Stereotype threat is a psychological phenomenon in which individuals from negatively stereotyped groups fear fulfilling stereotypes about their groups, and that fear impairs performance. So stereotype threat was first described at the University of Michigan, looking at women in mathematics. And what researchers saw were that in entry-level math classes, men and women performed equivalently. But as you went up to the higher level math classes, men began to consistently outperform women. And there was a group of thinkers, within our country and sort of worldwide who said, oh, women have just reached their peak. Like they can't do math at a very high level, and that men are just superior to women at doing math. And what these researchers have shown in a phenomenon that's now been redemonstrated in hundreds of studies is that women were being cued by the absence of men. And that cue was reminding them that society thought that they were less talented at math. And as people either consciously or subconsciously try to disprove the stereotype, they impaired their performance. And so what you'll see in all the stereotype threat literature is in a threatening situation where people are cued to negative stereotypes, performance is impaired. And then when you remove that threat, performance improves significantly. And I personally became interested in stereotype threat from a study that we did. This was a multi-institutional study looking at 6 medical schools and basically medical students' perceptions of assessment and of the learning environment. And one of our key findings was that higher stereotype threat was associated with worse performance during 3rd year of medical school. And, at the time, there's a lot of uncertainty there because you don't know, is it that people struggle and then they have more stereotype threat, or do they have more stereotype threat and then they struggle? In reality, I think that anyone who really thought about this mechanistically would say they're likely very fundamentally intertwined. But we were really, because stereotype threat is a very contextual phenomenon, we were interested in understanding how it manifests in medicine. And despite there being hundreds of papers in other literature, there's very little exploring it in medicine. So this leads to a study. I have a few studies that I'll sort of take a small deep dive into, which we call They Don't See a Lot of People My Color, a mixed method study of racial or ethnic stereotype threat. So as a critical researcher, I use both quantitative and qualitative methods in my research, and you really adapt your methodology to the research question, but I'm not beholden to any one specific research methodology. So I'm basically going to summarize this paper and say that we describe stereotype threat as a 3-step phenomenon, where first individuals are triggered, and you get triggered about, and we're specifically looking at race or ethnicity, but this certainly is consistent, with gender, et cetera, other identities. People are first triggered by the lens of race or ethnicity. This happens when things like microaggressions occur. In particular, microaggressions occur and no one responds, or when an individual feels that they stand out, that they're the only one of their identity. People also carry their past experiences and have expectations for how the learning environment will treat them. After people are triggered, they then go into this very intense, both cognitive and affective or emotional response, where let's say you have a microaggression, people say, oh, well, did that really happen? Am I just being too sensitive, et cetera, all these things. And ultimately, this leads people to do things to try to respond, prevent, or defer threats. One that stands out for me is there was one participant in one of our studies who said that they and their friend were often mistaken for like cleaning staff. And so what they started to do is they started to overdress and make it like very, very clear that they were a member of the medical team. And that people are really spending a lot of cognitive energy like thinking through these things. This quote is my favorite quote from this study. So this is a learner who was asked a politically contentious question by their attending. And the learner said, do I want to give an answer that's going to appease them and maintain a good relationship? And it's a big loaded question when I'm trying to think of the differential for altered mental status. So this really highlights the fact that learners are experiencing these very polarizing sort of interactions while they're also trying to learn. And that can often impair learning. Mechanistically, this occurs through cognitive load. So cognitive load theory is a theory which says we all have working memory. And a working memory is a memory that we use to sort of deal with the tasks in front of us. And the working memory at any time must accommodate, one, the intrinsic difficulty of a task. So, something that you've done once or is very different than something you've done 100 times, the intrinsic difficulty of doing something. The extraneous load, which are the distractors, which take up working memory, but don't help you accomplish the task. And the germane load, which is essentially the part of your brain that you use to learn, to manipulate, to retrieve like files. And what happens in stereotype threat is individuals have significantly increased extraneous load. The distractors basically consume the working memory so that you don't have space in your brain to deal with the tasks in front of you. And this mechanism, again, has been consistently redemonstrated throughout the literature. But additionally, Stereotype threat is thought to lead to something called domain disidentification. So when you study people, one of the interesting findings about stereotype threat is most impairing for the things that you care about the most. So the more strongly you relate to an identity, the more I want to be a surgeon, the more impairing stereotypes related to me being a surgeon are. So if you take students who don't care about math and science and you give them a threatening situation, it actually doesn't really impact their performance. But when you take people who care about science, it really impairs their performance. And what happens when you have chronic stereotype threat is that people begin to disidentify with those domains that they previously really cared about. And so people will, in some ways, a coping mechanism, you could say, is you disconnect yourself from this identity. And this ultimately can lead to people leaving, quitting, not doing that thing which they previously really cared about. This photo is from Dr. Uche Blackstock, who basically was talking about why Black physicians are leaving medicine in droves. And she talks about many things, but I think stereotype threat is one of the big contributors. So as I was doing this study, there was a point where it started to feel a little bit depressing. There was all of these kind of challenges that people were facing, and they're really, I don't know. So one of the things I asked learners as we went into the study was, where do you feel safe? Where do you feel protected from stereotype threat? And learners talked about teammates, residents, attendings, mentors who really did things like disrupting the initial triggering. They responded to microaggressions. They called things out. They used these challenging opportunities as teaching moments. And learners really felt like that was something that helped to mitigate stereotype threat. And so this leads me to the next study that I'm going to tell you all about, in which we spent some time. I mentioned that microaggressions were a key trigger of stereotype threat. So we were interested in understanding how we could most effectively respond to microaggressions. I think we've all heard the term microaggression at some point, but just to make sure that we're all on the same page, a microaggression is a verbal, behavioral, or environmental indignity that signifies hostility to one's identity. And microaggressions occur regardless of the intent of the source or perpetrator of the microaggression. It really depends on the impact or how it lands on the person who is at the receiving end or the target of the microaggression. There are different types of microaggressions. Microassaults are the most flagrant. Microinsults are these things that people oftentimes unintended. So calling a female physician a nurse, the word nurse is not an offensive term in of itself, but when someone is a physician and they consistently are mislabeled as someone who has, quite frankly, less power in the medical hierarchy, it becomes a microaggression. And microinvalidation is when people sort of discount the experiences of other individuals. Microaggressions are also physiologically and psychologically impactful. They're associated with worse mental health outcomes, anxiety, depression. They are associated with substance use. They're associated with changes in cortisol secretion. And as I mentioned, they are fundamentally in the causal pathway of stereotype threat. Okay, so hopefully I've checked off my first objective that we talked about some. This is by no means an all-inclusive list, but just something. I'm going to finish the microaggression study in a moment, but some of the things that are identity threats. So these identity charged incidents that have negative implications on the receiver. So we're going to talk about now intervention. So what can we do to mitigate these identity threats? So I'll start here with Maslow's hierarchy of needs. So Maslow was an American psychologist, and he basically came up with this pyramid, which basically says all humans have a desire to reach self-actualization, to achieve your full potential, to be the surgeon that you were born to be, to et cetera, the parent, the everything. But in order to achieve self-actualization, there are some core fundamental needs that must be fulfilled before you can get there. In the most basic level, humans need food, shelter, water, et cetera. On the second level, though, is this need for safety, that you can't progress towards self-actualization until you feel safe. And if you study the blood of these people, who are undergoing identity threats, you have changes in the way that their stress pathways, their hormonal pathways are functioning. And so people are actually perceiving personal threats as threats to their safety. And so I would argue that we, fortunately, not everyone, but most physicians are in a place where their core physiological needs are being met. So I think it's important to attend to safety. So I mentioned microaggressions. So this study, this is a visual abstract of a study. When you look at the literature on how to respond to microaggressions, there are a lot of different frameworks listed, but when you actually unpack them, you'll see that very few, if any, have evidence base underlying their recommended interventions to microaggressions. It's most often expert opinion, which is valuable, but I would say there's some limitations. And so we were interested in starting to build an evidence base to inform microaggression interventions. And that fact that I said about there's little evidence base, that's in all fields, even outside of medicine. And one of the things I didn't mention about critical theory is that one of the key tenets of critical theory is that you must center the most marginalized in society, those individuals who have the least power, if you truly want to make meaningful change. And so what we did, naturally, thinking about the physician hierarchy, which admittedly is a already empowered subset, we went to talk to medical students, and we basically asked them, we gave them some scenarios, and we said, hey, if this, what we thought were pretty realistic microaggression scenario happened, how would you feel most supported by your team? And from this, we developed this three-step sort of, we like three-step sort of recommendation that we should divide microaggression responses into a before, during, and after. So before response, we would say that, on formation of a new team, you should have a conversation, which can be brief, which can be like 2 to 3 minutes, which says, we acknowledge that microaggressions exist. I want to create a safe space for everyone. We all are learning, including myself. I may commit microaggressions in our time together. And I want to talk about how we would feel most supported in the event of a microaggression. And you actually ask people what they want. And this is very powerful because inevitably, and I would say every single time that I do not do this, a microaggression happens within like 4 hours. Because what happens is in the moment, many people have this uncertainty of not knowing how to respond. So classically, if I have, for instance, a woman attending and a patient microaggresses them, my question is always, well, should I intervene? Or is me intervening being a man and I'm like sort of assuming that this person can't respond for themselves? Am I committing an additional microaggression by trying to respond for them? All these things, and then the moment passes and then nothing happens. And the only thing that I would say that's definitively clear is not responding is clearly the worst option. And so in the moment, unless someone has explicitly told you to not respond, your default should be to respond to microaggression. There are some times where things are happening that are particularly flagrant, where you should end the interaction for the person who's being targeted by a microaggression. An example of this would be once I was in the ICU and we were rounding and a patient started yelling like the N-word over and over and over. And like no one on my team said anything and I was presenting. So that was a moment where one, me going into that room was clearly not going to de-escalate that patient. And two, I would have appreciated if anyone on my team had said, let's pause, walk away from this room, and like we can continue presenting later. But oftentimes people just are paralyzed. And the importance of having a framework is you have a framework. And then when you're in the moment of stress, you can respond. And then finally, after, in medicine, where I trained, there was this big default to after something uncomfortable would happen, you would debrief as a whole team. And what a lot of learners said was that that's actually not very helpful because most often no one responded in the moment. And then you do these big group debriefs where everyone tells you how uncomfortable they felt. Obviously we're medicine, so we like to talk for a long time, but instead it would be more helpful if you one-on-one, you said, I saw that happen. Do you want to talk about it? And then just default to whatever the learner says. So this was So this is the first study we talked about with microaggressions. We have a second study, which is led by Dr. Megan O'Brien, so this is from the learner side. We then took it to the faculty and said, well, faculty, like, what do you think of this? Does this feel like a realistic thing that you would actually implement? And I would say the surgeon relevant feedback that I would say is many surgeons said, my teams change so frequently that like, I can't do this every single day. And that this would be challenging to operationally implement. And that is something that we are thinking about. And I would say requires more research. But I would definitively say, one, this can be done very quickly. And two, if something happens, to me, that's a signal that you intervene and then you start from the beginning of the pathway. They take it as an opportunity to be a teaching moment for the team. But one of the things that struck me as we move further into this research is that I feel like so many of our interventions to create equity or justice in our learning environment, they center the threat. And by centering the threat, you're actually inherently centering those people in power. And I would say, what if we centered safety? What if we centered the protection of the person who's in the center of this entire experience? And acknowledging, I'm specifically talking about the learner pathway. I think this is very relevant similarly to patients. So there are many different forms of safety that have been described in the literature. The one that I'll highlight that I'm sure everyone has heard of is psychological safety. Psychological safety, its whole emphasis is on power and on leveling power dynamics and power hierarchies. And there's a lot of literature that shows that in psychologically safe environments, people feel more safe to disclose errors, to question leadership in meaningful ways. And there's also some literature that suggests that I think it's more of a theoretical, I don't know how much actual evidence base there is, that individuals of diverse identities in psychologically safe environments feel more safe to come forward. And that is good, but I would say there are some limitations to psychological safety. In most of the forms of safety, the person who is receiving is often viewed as this sort of passive vessel, that everyone else around you creates safety, but that you're not involved in the creation of safety for yourself. And second, identity and the benefits of identity are really thought of as an afterthought. And I am someone who has many minoritized identities. And for me, feeling safe in my identities is not an afterthought. I feel that I can't perform optimally until I feel seen as a human. And so I would say that there's a lot of different things that we talk about in medical education, which highlight that identity matters a lot. I've talked already about identity threats. The whole purpose of medicine is this professional identity formation, that you come in as a novice, a not medical professional, and you have this whole reconciliation process where your personal and professional identities must reconcile. And in the process, you're forming your professional identity as a nephrologist, as a vascular surgeon, et cetera. In the process, there's this construct of professionalism, which we talk a lot about, which is a little bit of a contentious topic in some circles. There's this, and this is saying that if you hold a specific identity, you're supposed to behave a specific way. Identity dissonance, that through this professional identity formation professionalism, sometimes your personal identity conflicts with your professional identity. And this can be a challenging sort of reconciliation process. And specialty selection, so often I heard, go where your people are. And inherent in there is like identity, that you go to people who share some identity traits to you. So I think identity is very prevalent, even if we don't sort of specifically call it that. So I'm going to get to identity safety, and I just want to share one personal thing, because I think in critical research, and qualitative research in general, but in particular in critical research, this notion of an objective researcher does not exist. I would argue that in any field, we all bring our personal viewpoints, beliefs, and identities, and it informs the work that we do. And from a critical perspective, like thinking about myself, my identities are actually a strength. because they are the tools through which I like view the interactions, through I form connections with my participants, which I understand the data. And so I would say this is an example to show a time where I went from feeling extremely identity safe to very identity threatened. So when I was an intern, in December of my intern year, I wrote this piece that ended up getting published in the New England Journal of Medicine. And I think most people would share a similar belief that institutions like that, it's a very favored thing. Even if you're talking about something very contentious, if you publish in the New England Journal of Medicine, people are usually happy. There's a lot of power dynamics tied in there. And so at that time, I felt very supported, where I talked about, I wrote this piece about being bipolar and my experience with suicidality. And it was a very kind of honest piece. And so I felt very safe in that sense to be myself, to be my authentic self. Later during intern year, I attempted suicide, and it happened in a way before that, I had absolutely no work issues whatsoever. My suicide attempt happened outside of work. I actually called 911. I did like this month-long program and was cleared to return to work. When I tried to come back, I faced immense discrimination and bias from the same institution that had really praised me before. And had to do all these like drug tests and like all these things. And I felt very not supported by my program leadership. I say all this to say, when I came back to work, before I had not had many issues, and I was actually psychologically doing better from my bipolar perspective. But I remember feeling so anxious. I was so afraid that if I made any mistake at all, I was going to get like kicked out of my program. They were going to blame it on my mental illness, and then I was going to have to go. And so I went from this place of feeling so safe to feeling like incredibly threatened. And I didn't realize that I had felt safe until I didn't have that safety. And so that is very deep. That's very important, I think, for everyone to know as I began to think about this, what it means to actually feel safe in your identities. So this leads me to the third and final study, which I'm going to tell you about in a little bit more depth, which we call "You Can Be Yourself in All Your Forms: A Grounded Theory Exploration of Identity Safety in Medical Students." And I'll say, so this is a paper that we are hopefully submitting in like the next 1 to 2 weeks. So I would very openly accept any critical or not critical feedback about it, because we're doing some really cool like theory building work. So we use this methodology called the grounded theory, constructivist grounded theory. Grounded theory is a methodology which, as it sounds in the name, is made to create theory. So you're supposed to be working in space where theory does not exist in order to create a theory that describes some phenomenon or other thing. In grounded theory, there are many sort of specific methodological decisions that you have to make. First, there's this thing called maximum variation sampling. So to create this theory, you want to test the bounds. So you want to test extreme cases of, we're talking about identity, so we wanted to have, and we did have, the like queer Black woman immigrant, and you have the person who self-describes as like white male conservative Mormon, and all non-binary, indigenous person, like people who have all sorts of different identities to really test the space and who have high and low stereotype threat. So first, that's a very intentional methodological sampling decision. Second, so we did a qualitative interview study. And in the process, you do this thing called constant comparison, where you're building your theory, and with each person that you sample, you're basically comparing them to your theory. And you're saying, does this person fit in with this like theoretical understanding that I have right now? If not, like, how do I build out my theory to explain them in? And then what do you do with the people who are outliers? Thinking very intentionally about all of those things. So I say all this to say, it's a very rigorous methodology. And what the sort of original theorists of grounded theory would say is, a well-done grounded theory study can never be disproven, because your theory is grounded in your data. So for at least the subpopulation that you're talking about, it was true at that point in time. So what does this have to do with everything that I was saying before? So I'll start off to say that a lot of the work before was emphasized responding to threats. And what became very clear is that environments in which threats are simply responded to is not safety. So one learner said, I often will wear my hijab in a turban style or like a scrub cap, but I'll always cover my neck. And I never had issues with that until one day a scrub nurse said I couldn't wear that. So the resident who was in the room was a Muslim male, and said like, hey, well, clearly I'm wearing something that's like covering my neck too, but you're not saying anything like this, there's a double standard, and this is for her faith. But the scrub nurse said, no, like students still had to change. And the student said, yeah, I really appreciated having someone in my corner in that moment. And even though the outcome was that I still had to change and wear something else, he apologized on their behalf. So I really appreciated that resident. So one of the themes that kind of what comes out a lot in the data is you ask people, but did that feel safe? And they'll say no. And so it's very clear that it lessens the cognitive and emotional impact, but it's still a threat. So this is one of the figures. We worked with someone who I thought was a good graphic designer. And there are many different identity threats. These are just some. I want to explain two concepts. Social political threats basically refer to the way that the news and the news cycle actually impacts people's feelings of safety. So for instance, the learner who identified as conservative Mormon talked about when Roe versus Wade was in the news, that he felt very unsafe. He said, it's not that I wanted people to believe what I believed, but I felt that if they knew what my beliefs were, that I would be like judged poorly for it and actually penalized in assessment. And they're similar for, with like police, like killings, slayings of Black individuals, or anti-Asian hate, like all of those things change people's feelings of safety when they're in the hospital. Things outside the hospital impact what's going on inside the hospital. And then finally, this concept of lack of identity safety. I have a story for this. So when you lack safety, it's perceived as a threat. So this is a story which I sort of title like Purple Scrunchie. So there was a learner who was interested in general surgery. They actually did a year-long research in surgery as a medical student. And they said, it's not like they were mean to me. They didn't do anything like wrong. I just feel like I didn't belong. And like the hobbies that people shared, I didn't share those hobbies. A lot of my hobbies are very culturally. This person's a Filipino woman, said a lot of the hobbies, or I have culturally related hobbies, and I didn't feel safe to talk about them. And eventually, this person, despite saying that they actually really enjoyed surgery, decided to not do surgery and decided to do dermatology instead. And at this particular institution, they felt that there were more women and more diversity. And they were like, she said, for instance, I have this purple scrunchie that I didn't wear for the entire year that I was on surgery. And I asked her, did you ever go back to wearing this purple scrunchie? And she's like, yeah. And I said, can you tell me about the first time? And she said, I got on my outfit, and I typically like to wear colorful touches in my wardrobe, but I hadn't for a while. I got on my outfit and I looked over at the scrunchie. And in that moment, I realized how much of myself I had given up to try and fit in this other environment. And it sounds so silly, but now it's just so nice to not have to overthink really small details like what I'm wearing, the scrunchie that I'm wearing in my wardrobe. And so I think, again, the point that I highlight is this person said, it wasn't like they were mean. It wasn't that that they were actively bad, but still somehow they didn't feel safe. And I think because of this, many specialties, but I think for this particular person, surgery is losing out on these potentially amazing people who actually have interest in the field because they don't feel like they belong. And so we call this state of responding to threat mitigation. We say threat is not gone, but it's dampened. So I've talked around identity safety for a long time. I guess I'll finally tell you what it is. So we say that identity safety is the ability to exist as one's authentic self without worrying about others' impressions of one's identities. Identity safe environments value each person's identities plural, and empowers individuals to leverage those identities to improve patient care. So I'm going to talk to you now about the pillars that define identity safety. The first, and this is probably my favorite, is what we call agency to serve. every single learner, regardless of identity, every single learner that participated in our study had explicit examples of times that they used their identities productively to help patients. That people are both aware of their identities and they see people who share their identities and they play them like cards to help patients. So I'll give you some examples. So my attending said, they're referring to this person has type 1 diabetes, referring to a patient. He doesn't seem like a very controlled diabetic. He's not really someone I think of as a candidate for an insulin pump. And the learner said, and I got to kind of advocate like, no, this is the standard of treatment. Everyone should be able to access this. I got to advance patient care in that way. And my attending, I think, appreciated kind of learning from me in that aspect. So one of the things that you see is that learners, in the process of advocating for patients, they bring value to those identities. And in doing so, this value to one's identity creates a sense of identity safety for the self and also for the patient. Another learner, this person is a kidney transplant recipient, encountering a pre-op interaction with a patient. He basically went up, he was basically talking about how he's very thoughtful about the pre-op time and how to like share or not share his specific experiences. And he said, I told the guy that was getting a transplant, by the way, I was just going to let you know that I had a kidney transplant myself. It went really well and changed my life. And I hope the very best for you. And yeah, the patient loved it. It's these small interactions of using your identities to help comfort patients in times that are very scary. The final one that I'll give is that people use their, especially medical students, often feel, I think most people in medicine, often feel afraid of overriding the medical hierarchy. And professionalism is oftentimes viewed as something that is sort of punitive or tries to keep people in place or promotes conformity. And some learners will use their agency and even like sort of not disregard, but override professionalism. So one learner says, the surgeon was speaking to the patient in English, just going off with the treatment plan, everything in English, and the patient and context, the patient highly preferred Spanish. I stepped in and started translating, and I was like, I'm here, I'm gonna do better for this. And after that interaction, the surgeon basically, as we're walking off to the next patient, was like, don't do that again. There's a way we do things here, and you need to stay in line. And I think everyone could imagine a situation where if that exact learner then did the same thing with the next patient, that learner would get a professionalism flag and be viewed as not following the medical hierarchy. When in reality, I would argue that the surgeon who's speaking in the patient's non-preferred language is actually the one who's committing a professionalism violation. And we can talk about the fact that obviously people should be using like certified interpreters and all those things, but like I would argue that someone who, I would argue that whatever the optimal situation is, this certainly is not it. And I think this is really important because we think about how things like professionalism are disproportionately yielded against people of minoritized backgrounds. And to me, this is like one example of probably why it happens. Next, upholding personhood. So upholding personhood refers to times where a learner feels that other people are interested in knowing them as a person, that they feel seen in their identities, but not reduced to their identities or not tokenized for their identities. So here's an example. One learner was talking about how, and this can happen in very brief moments, in between surgical cases. One of the female surgeons on the team took me out for coffee and we talked about life and eventually led to gender stuff. This learner is non-binary. She's like, I have a 1-year-old son. How can I teach him to enjoy exploring gender? That felt really respectful and caring, like I got to meet you, not like I got to meet a trans person. And I think for many people, there's this fear, I think in particular for people, I know participants for sure, participants who are white, especially around race, of like, people, white, male, people who had more majority identities, often felt fearful of sort of moving into this space because they didn't want to misstep. But in so doing, they essentially don't allow people the opportunities to share the parts of themselves that are very important to who they are. The example of this, I would be like a different example would be in the Stereotype literature. There is a study where someone told a white individual that they were going to be having a conversation with race with a Black person, And so there's one situation where they said it was going to be a Black person, another one where it was a neutral sort of situation, and they had to set up 2 chairs. And in the conversation where they told they were going to have this conversation with a Black person, they put the chairs further apart, and because people are sort of subconsciously trying to avoid, these potentially contentious topics. And I would encourage you to not do that, but to do it thoughtfully. And finally, belonging. I think this one makes sense. Belonging is seeing people who look like you in the learning environment, who share some identities of yours. Learners talked about how things like one scrub nurse who shared an identity with the learner would give them like expired suture, and that made them feel like they belonged and they were sort of advocating for them and in their corner. So together, these 3 pillars, agency to serve, upholding personhood, and belonging, are the 3 core features that define our theory of identity safety. And I would say this is very, very different from responding to threat. I hope that is clear. So hopefully we've done checkpoint number 2. And finally, I want to talk about the implications. So a theory is only useful if you can lift things with it, if it can do something. And so what can you take from identity safety? So the first thing is, as I mentioned before, most of the other theories of safety, the person at the center is not viewed as an agent who can create safety for themselves. And I would say, to me, this is one of the reasons that some learners, you ask them well, why do you stay in this environment if it's so toxic? And it's because they are leveraging this agency to serve, but you can only do so much work for yourself to fight against these environments. And secondly, I think that all the examples that the patients gave, I would say they very clearly improved care for patients. So this should be a valued part, more than just recruiting people with diverse identities for numbers, but that they actually are contributing to learning environments. Second, an identity safe environment does not mean an environment that has no threats. It does not mean a homogeneous environment. Learners felt safe actually in diverse environments that were centered on respect. And that's why most learners actually independently said that they felt safest in the county hospital, because there were people of just many different identities, and staff and patients and everyone were sort of used to more identity interactions with people who were not the same. And another thing about upholding personhood is that this concept of bridging across differences. So often, the narrative is, we need to recruit more Black people so the Black people can mentor the Black people. And what happens is, I exist in an apartment with 2 Black faculty, and I like both of those faculty, but you come in and it's but what if I didn't? And then who's going to mentor me then? And somehow we sort of tell ourselves this narrative that the only person who can mentor a person of X identity must share that same identity. But I think our work, as an example I didn't give, but of a learner who was talking about a mentor who sometimes misgendered them, but because their relationship was built in trust, and that this mentor really apologized and tried to do better, there was still a sense of safety. So we can bridge across differences. We don't have to have the same. I think there's clearly value in having identity concordance, as Q belonging, but it's not the end all be all. And the other thing that happens is when you consider bridging across difference to be important, you basically no longer put all the burden for equity efforts onto people with marginalized identities. It's everyone has a role in this, and everyone can mentor. My main mentor, I'll show you at the end, is a white woman who is amazing, who I feel really cares about me as a person, knows who I am, and is able to still mentor me even though we don't share the same identity. And finally, I think that through the both sense of belonging, mitigating, I think identity safety both does work in and of itself, and I think it also helps fight against identity threats. It helps optimize performance for all. Even if you have the perfect assessment tool in a biased environment will lead to a biased outcome. And so if you have a biased environment where some people are disproportionately disadvantaged, then you're not going to fairly assess people. And I would say that identity safety promotes equitable assessment. And finally, we so often see loss of trainees, and people always wonder, we don't know what we could have done differently, did all these things. And I would argue it's because learners don't feel identity safe in the places where they exist, and so they leave. So future steps, I have 3 here. I'm currently working with Dr. Desari on something called dual ethnography, or collaborative autoethnography. Autoethnography is study of the self to understand the culture. And so the two of us are sort of combining forces and really talking about our experience in subspecialty fellow training and how they intersect with our identities. And I think have some very interesting findings. This is a very this study goes against a lot of things that most people in medicine would think about because it's a small number of people and all these things. But the thing that you gain from studying a small number of people very intensely is depth. I'll leave that there. Hopefully you'll be reading that soon. We're soon to start a multi-institutional longitudinal study, also in fellows to describe this evolution of these 3 pillars of identity safety. I believe fellows to be a particularly interesting subgroup, considering the medical power hierarchy, because they're not med students, they're not residents, they have some more power, but they're also not attendings. And so they exist in this very sort of, not limbo, but limbo space. And then finally, we're working on a structural equation modeling study, basically to examine the relationship performance, identity safety, and identity threat. Thank you very much. These are just some of the many people who I've worked with. This is my mentor, Dr. Karen Hauer, who is, I respect her for so many reasons, but I think one of the biggest things is from the very beginning of time that we worked together, I felt even as a third-year medical student that she treated me like a colleague and she respected my opinion. And when our first study, I brought this idea of, hey, I'm like thinking about this thing about stereotype threat. Like, what do you think? She was like, yeah, I love it. Like, let's do it. And I think it takes a special mentor to be willing to like actually truly consider the person they're mentoring as a colleague. I think not everyone does it. And thank you very much. If you have any questions, I'm happy to take them.